It's Dr. Max Cohen, and today we're going to be talking about clinical dermatology as it pertains to athletic trainers. I have a bit of an agenda here, basically to describe lesions and then understand a little bit about the diagnosis and management for infections, different types of dermatoses, urticaria, psoriasis, acne, skin cancer, and a little bit about just some more emergency situations in the world of dermatology. Quick note on wrestlers. I think this is probably going to be a bulk of the derm exposure that you will have clinically, as there's frequent skin-to-skin contact and um, having fomite of the mat to pass infections through. And so this is going to be sort of a important means of prevention, and also probably going to be responsible for most of the skin conditions that you're seeing clinically. So when we're getting a good dermatologic history, you want to know about the onset and the progression of that rash. Is it getting better? Is it getting worse? Has it evolved in any particular way? Is it associated with any pain, bleeding, itching, any redness, any particular lesions? If they have used any home treatments, over-the-counter treatments, what was the response? And then has it developed any new secondary characteristics? Is it associated with any recent travel or any particular exposures environmentally or through their job? And then understanding a bit about the past medical history, any allergies or medications that they're taking, and especially if there's been any changes in those um, medications. So there's a lot of words that we use to describe different types of lesions. When we are looking at these, it's good to get an idea of what's the color, what's the shape, what's the size, what's the location. If there's borders, is it well demarcated or more poorly demarcated? Did it develop any secondary characteristics? And where is it distributed on the body? And then we'll go into some of these words on the right side here. This is the difference between a macule and a papule. So a macule is a flat area where there's this color change, and this is an example is like a freckle. A papule is when it is a small raised solid lesion, usually less than a half, or some will say up to a centimeter, which you might see in like an allergic eczema. In a nodule, these tend to be slightly larger and extend deeper into the dermis, like a mole. Tumors are larger solid masses, like you might see in a squamous cell carcinoma. Plaques are elevated, raised surfaces that are broader than a centimeter, and you might see that with things like thrush. A wheal is a very superficial uh, swelling and edema, typically transient, and it's sort of a type of plaque, as raised sort of lesion. So you might see that with hives, or when you do a PPD skin test and they put a small intradermal wheal of the tuberculin substance. And then some of these fluid-filled lesions, you have vesicles, which are small blisters with fluid under that epidermis or in the epidermis, which you might see in a herpes infection. Bullae, which are large blisters, typically greater than half a centimeter or centimeter, and you might see that in burns. And pustules, which are pus-filled vesicles that you might see in things like acne or folliculitis. Here's a little bit of a summary. Feel free to pause and read through that. As far as secondary lesions, these are associated changes to the primary lesion. So this could be like scaling, where there's flakes of the cornified skin layer, as you might see in psoriasis. You can see crusting, which is a dried exudate on the skin, like you might see in impetigo, which we'll kind of go into more later. Fissuring, when there's actually cracks into the skin that you might see in athlete's foot, or tinea pedis. Ulcers, where you have destruction of the epidermis, so like a pressure sore, or maybe after a uh, vesicle has ruptured. Scars, where you have excess collagen production after an injury. This might be like somebody who had a surgical incision that healed up. And then atrophy, where you have some loss of like a portion of the skin, like you could see sometimes with paralysis, um, where there's some atrophy of that tissue. So we'll start with bacterial infections. Often these are going to be related to staph and strep. That's the gram-positive bacteria that is living on the skin in most scenarios. And so this is largely responsible for what you'll see, and then it can cause several different types of conditions that we want to kind of go through. So, folliculitis, furuncles, carbuncles, these are infections with inflammation of the hair follicle and sort can extend into the surrounding tissue. These are usually tender pustules and nodules, and often from a staph infection. When these are super mild, like just a couple folliculitis pustules, perhaps somebody was just in a hot tub, which can be a risk factor. You might just observe that. If it's a little bit more widespread or a little bit maybe more inflammatory looking, thinking about using a topical antibiotic like mupirocin. And then, if more severe or not improving, sometimes these need to be drained. If there's a very large collection, skin abscess, sometimes you need to drain these and think about using an oral antibiotic like Keflex, which has good coverage for these types of bacteria. Uh, Here's some pictures where folliculitis is that pustular lesion of the hair follicle, and then a furuncle is when you have more abscess from that hair follicle, or sort of there's extension of the inflammation, and then the carbuncle is when there's a network of these furuncles and they're sort of connected by different tracts, and they can get quite large and painful. And This is what people will the furuncles are sort of what are colloquially known as boils. Impetigo is another bacterial infection, typically a vesicular lesion that ruptures, leaving sort of this raw appearance, and then it's followed by a honey-colored crust of that, dried up exudate. Usually very superficial, typically group A strep or staph, very contagious, often in children, and we usually use topical antibiotics for this, like mupirocin. If it's more widespread, sometimes we think about oral antibiotics, especially if more severe. This is a picture of what that honey-colored crust looks like, very characteristic, so you want to be able to pick that up. For cellulitis, this is basically an erythematous, warm, swollen, and tender, poorly demarcated area, sometimes with systemic symptoms like fever and fatigue. And those are the keys to the diagnosis. You really want to have all four of that: warm, swollen, edematous, tender, and erythematous. And this signifies infection of the deep dermis and the subcutaneous tissue, and usually also caused by group A strep, but sometimes staph. Erysipelas is a particular sort of more superficial type of bacterial infection that's sometimes confused for a cellulitis. And the key here is erysipelas is usually very well demarcated because it's more superficial. And any real breakdown to the skin protective barrier, like bites or injuries, surgical incisions, any fissuring from like a tinea pedis, can increase risk. And these are typically treated with oral antibiotics, oftentimes things like Keflex, but with a more purulent nature, like if you see some, abscess component or fluid-filled component, or they have MRSA, which is methicillin-resistant Staph aureus risk factors. We'll talk about in a little bit. Thinking about adding on Bactrim or clindamycin along with the Keflex to cover for those extra types of organisms that can be sometimes a bit harder to treat. And then in some cases, these folks actually need hospitalization with IV antibiotic therapy, especially if it's rapidly progressing or very severe, associated with multiple signs of systemic infection, or if they failed outpatient treatment. So, what does failed outpatient treatment look like? Typically, when someone comes in and they have this red, swollen, tender area, so you can see that the borders are sort of a little bit hard to say where does this start and stop. But what we tend to do is we use a marking pen and then draw out a border to where we think that the borders are. And you give it 24 48 hours. You want to see it stop progressing. Sometimes the next day it might progress just a little bit, but then really by 48 hours it should stop progressing and start receding from that marked border. And that tends to tell us that we're doing a good job with the treatment. It's responding as we expect. And if it goes beyond that line, then we typically say, hey, you should get this further evaluated to see if we are requiring like IV therapy. Here is a couple pictures of that cellulitis versus erysipelas. You can see that there's like very clearly defined borders to the erysipelas, whereas with the cellulitis a little bit harder to sort of clearly make out the borders. MRSA is basically a type of Staph aureus, which is bacteria living on the skin typically, and it's resistant to methicillin, which is an antibiotic mostly for like research purposes. But it tells us basically a story of a bacteria that is no longer sensitive to antibiotics that it used to be sensitive to. And patients will often note that this looks like a spider bite. You'll oftentimes have some of that like purulent or abscessing nature to it, and will often require specific antibiotics that can cover for the resistant types of organisms. So the oral medicines that can do that are clindamycin, doxycycline, and Bactrim. And then for IV, sometimes we use something called vancomycin that would be given in the hospital for more severe cases. And we'll often treat empirically, meaning just assuming that there could be MRSA there, or there's a high chance, and so we're going to cover for it. But sometimes we also do check cultures of the wound, or sometimes we can do a swab of the nares to look to see if there's MRSA hanging out in the nose, colonizing the nose. Lyme disease is an interesting infection, and has gained a lot of popularity in the Northeast, discovered in Lyme, Connecticut. It's caused by the Borrelia burgdorferi spirochete, and typically patients will have systemic signs of infection like fever, myalgias, arthralgias, headache, and then they may have this erythema migrans rash, which is an annular rash, so circular bullseye rash. This is transmitted by the Ixodes tick. It typically will progress through three stages if it's not caught early. So you have a localized form, a disseminated form, and a persistent form. So it can actually affect the heart, the nerves, and it can eventually affect the joints and cause arthritis. So we're going to be doing a good skin exam, making sure to assess for this possible rash, and then looking for a tick and seeing if you can remove it if it's still attached, making sure to get the whole thing intact, and then treating with doxycycline typically. Here's an example of that annular rash. You can see sort of a red center portion and then a red sort of ring portion around the outside with that clearing in between those two areas. And for most bacterial infections, we're thinking about antibiotics, and you're just trying to decide, is this going to respond to topical versus oral? If it's severe, do they need IV? Does it need an IND, which is an incision and drainage, if it's a deeper abscess? And then for return to play, typically the guidelines are no new lesions for at least 48 hours, antibiotics for at least 72 hours, and no draining lesions. You can't cover any draining or active lesions to play. Prevention, talking again about disinfection of those high touch surfaces or the mats for wrestlers, covering wounds, not sharing personal items, shaving equipment, etc. As far as viral infections, some of the most common ones that we're concerned with are the HSV virus, type 1 and type 2, molluscum contagiosum, and then viral exanthems. HSV is characteristically a coalescing grouped vesicles on an erythematous base, often preceded by a prodrome where patients will report sort of like a tingling or burning sensation in that area. And that's because the herpes virus can live in the nerve cells after an infection, and can then recur and come out in that distribution into that area, often in times of stress or illness to the body. And typically treated with acyclovir or valcyclovir. There's also topical treatments. The ones that you're probably most commonly going to see are this orolabial HSV infection on the picture on the left, or what we call herpes gladiatorum. The picture on the right, you'll see those grouped vesicles. You can see that some of them are starting to sort of coalesce and smush together, and they're on that reddish erythematous base. Molluscum contagiosum, these are fleshy papules that have a central umbilication caused by a pox virus. So you can see particularly that one on the left of this picture, there's sort of that dimple in the middle, and that's classic for molluscum contagiosum. And these are benign, harmless, but they are very contagious, and so we need to treat these with either cryotherapy, which is using a liquid nitrogen freeze spray to destroy these, or the guidelines actually from NATA say that they need to be curetted and by a physician, so actually kind of scraping them out to destroy these lesions before somebody can participate. Viral xanthems are widespread erythematous, often maculopapular eruptions that come up in the setting of a viral infection. So this is somebody who's got fever, chills, headache, malaise, and then they end up with this rash. The etiology can sometimes be from direct damage from the virus on the skin. Sometimes it's related to the immune response or a reaction to the toxin. And in a sort of an interesting special case scenario, folks who actually have mono but are treated for strep with amoxicillin will see a sort of a similar rash appear. And so that sometimes is an interesting clinical scenario to be familiar with. And treatment's usually supportive, depending on what kind of virus this is. There's a number of common viruses, but having sort of some suspicion for some less common viruses, and so asking folks about their immunization status. Are they immunized for measles, mumps, rubella? Because those can present with viral xanthem and have greater public health implications, as you could imagine. And this is sort of what that looks like. So when we see some of these flat areas, some of these bumpy papular areas, we can call that maculopapular. That's how you would sort of describe that rash. So we'll move on to fungal infections. Tinea being sort of the more important one for the athletic trainer. And you can have tinea, which are these dermatophytoses, fungal infections on the scalp, which is a capitis, which typically presents with a scaly patch, some broken hairs. Corporis, which means on the body, and these are those ringworm lesions that you're probably familiar with seeing, annular with a clear center. The tinea cruris is basically jock itch, typically the inner thigh and the groin affected. Tinea pedis, or athlete's foot, where you have scaling and fissuring. Tinea versicolor is sort of a specific form, and this actually is typically a hypopigmented patch, and it's not really a true tinea, but we do call it tinea versicolor, so I just wanted to group it in here so it's something that you're familiar with. Onychomycosis, which is fungal infection of the nail, and seborrheic dermatitis, which is basically just dandruff when you have that white, yellow, waxy scale and hair-bearing areas, and that's typically caused by the Malassezia fungus that lives on the skin. And these are some pictures here of, on the top left, capitis, moving to the right, ringworm or corporis, in the bottom left, tinea cruris, and on the bottom right, tinea pedis. So you can see how sort of the morphology will change a bit, and you can see how they, the cruris, for example, there's sort of that erythematous, well-defined edge on the groin there. Where that fungus is overgrowing and irritating the skin. On the right, you can see the fissuring associated with tinea pedis, and you could sort of recognize how that could allow for other infections to more easily get through the barrier of the skin and cause things like a cellulitis or other types of infections of the lower extremity. And this is onychomycosis, and you typically get thickening, yellowing, and sort of dystrophy of the nail plate, and the nail growing in an abnormal sort of form. It can often spread to affect other toes. This is seborrheic dermatitis. This is basically dandruff, so you can see these like whitish yellow areas, a little waxy with a bunch of flaking. And the treatment is basically antifungals for all these things, including tinea versicolor. This is the hypopigmented macules and patches that are harmless, but caused by sort of this fungal pathophysiology. And people will often notice that when they are in the summer, they're just sweating more, and they maybe have some tanner skin. It's easier to notice these lesions, and they're more likely to sort of be exacerbated. And we can treat them sort of in a similar way with a ketoconazole shampoo or cream, and that'll often improve the appearance if somebody wanted to treat that. And largely these are going to be treated with either over-the-counter, antifungals, or sometimes we need prescription strength if it's not getting better with the over-counter, or more severe, widespread, distribution. Sometimes we do need prescription medicines. Lotrimin being sort of one of the more common ones that you've probably heard of. And these are medicines like clotrimazole, ketoconazole. They all end in the azoles. That's characteristic of antifungal medicines. Typically for toenails, we need to use oral antifungals. They just don't tend to get better with topical. And if you are going to use topical, you typically have to treat for a full year. So fingernails sometimes respond to topical treatments, but really thinking about oral for the toenails. And then for seborrheic dermatitis, using a ketoconazole or a Selsun blue or something like that to suppress the fungus that is causing the dandruff. And then we'll talk a little bit about return to play in a second. Here's a summary of some of the infectious etiologies that we talked about, some of the clinical features, so you can feel free to pause and read through that. And then here is a summary of the return to play guidelines for some of these important infections as they pertain to the athletic trainer, and including some of the bacterial, viral, and fungal conditions that we just talked about. So I would take a read through that, and then we'll discuss more in class. Moving on to contact dermatitis. So there are sort of a couple kinds of contact dermatitis. There can be an irritant, more immediate onset, and there can be an allergic contact dermatitis, more of a delayed hypersensitivity reaction. Some of the etiologies are things like poison ivy, nickel, detergents, different dyes. So when you're getting a good history for these patients, you want to be asking about any of these kinds of exposures. And oftentimes this will look erythematous. They'll be really itchy, or what's called pruritic. And oftentimes you'll see these very small vesicles or bullae that are fluid filled. If you see any linear components to the rash, that's often suggestive of contact dermatitis. And you can, starting in the picture on the right, you can see how those vesicles, or these small vesicles on sort of these erythematous areas, you could say, oh, that one in the middle there is very linear. That maybe makes a suggestion to me of more of a contact dermatitis, as something sort of like brushed along that area and created a linear pattern. And then in the picture on the left there, that's a finger, and it looks like this person had a ring on, and that distribution is very common for somebody who had, like, for example, a nickel based ring, and they didn't realize they have this nickel allergy, and then they wear the ring, they end up with that, or folks who have nickel based pendants on, and they end up with their necklace along their neckline or on their chest, that they have a rash that sort of looks like this. Treatment is usually corticosteroids to decrease inflammation and reduce itch, oftentimes topical for more local conditions, but if more severe diffuse, we do think about oral steroids, antihistamines like Benadryl, the sedating ones, or the non-sedating ones like Zyrtec or Claritin can be helpful for reducing the histamine release and itch, and helping people to get to sleep at night. The cool wet cloth, topically can be comforting, and then these will typically get better in 2 to 4 weeks. Atopic dermatitis is a type of eczema, typically associated with a lot of dryness. These will often be seen in a triad where the patient has asthma, allergies, and eczema or atopic dermatitis. So it's helpful to ask about history of asthma and allergies in patients with presenting complaints similar to this, so that you can sort of increase your likelihood ratio, that this might be eczematous. And in a lot of cases, people have primarily rashes that become itchy. This tends to be called the itch that rashes. So it tends to be itchy. They scratch it, it gets red. You get crusting and fissuring, and then over time, you can actually get what's called lichenification, where the skin gets thickened from chronic scratching. It's often in the flexor surfaces, and you'll get these erythematous, patches and papules that are very itchy. And the treatment is really hydration. You can see here that this is basically different sort of grading scales for different levels of swelling, different levels of redness, different levels of scaling, different levels of dryness, and the more severe presentations to the right, more mild to the left. And so we want to moisturize, thinking about putting on an Aquaphor or a Vaseline, particularly after somebody showers, to try to kind of lock in that moisture, and using corticosteroids as needed, typically topically, unless, again, severe, to decrease that itch and inflammation, make the patient feel better so they stop itching as much, and then antihistamines can also be helpful. A quick note about the difference between ointments, creams, lotions, etc. It basically depends on how much water is in it. So on the left, you have pure water. On the right, you have pure Vaseline, which is polyethylene glycol. And you have in the middle there creams, which is sort of a 50-50 split, and more towards the water side. If you have a greater degree of water, you get lotions, and then if you have more Vaseline and more oily, you have ointments in the middle of there. So these are going to be really thick, as opposed to lotions, which are going to be a more thinner, easier to spread. Urticaria is characterized by hives or that swelling in the superficial dermis, typically fleshy, very itchy, with well-defined borders. this is usually an IgE mediated mast cell degranulation. So mast cells are responsible for releasing histamine, and histamine is what causes swelling and itch. And these lesions will tend to pop up and then go away within 24 hours, and they pop up in a new place. We usually treat this with antihistamines, and we sometimes treat it with steroids if it's really bad. And this is kind of what those wheels look like. It's a well-defined geometric plaques. And I just want to talk briefly about angioedema. So this is edema that's in the deeper dermis, and it's through a different pathophysiology. It's actually bradykinin mediated. You get vasodilation and increased vascular permeability, so you get basically leakage from the blood vessels. And this is often in the setting of certain medications or familial, there's a condition called C1 esterase inhibitor deficiency. And people can swell rapidly and severely. So we want to be thinking about getting them emergency care if there's concern for airway compromise. So people will have this severe swelling, often associated with a raised itchy rash, and the swelling can be around the eyes, the lips, the feet, the hands, the genitals. And you can imagine that if the tongue is swollen to that degree, it's going to make it very hard to get air, from the outside into the lungs. So this can be very dangerous, and patients really need to be managed in the emergency department. Psoriasis is a autoinflammatory condition that has a papulosquamous eruption, essentially from rapid cell turnover that's sort of inappropriate, and it forms these thick plaques. We call them salmon plaques, or they're sort of pinkish, and then they have a silvery scale on top. This is often on the extensor surfaces as opposed to eczema and atopic dermatitis, which we say is usually on the flexor surfaces. So you'll see this more on the elbows, knees. Sometimes you'll see to the scalp or the low back. You may get nail pitting with that. So when you look at the nails, you can actually see little indents, and this can cause psoriatic arthritis. So you can actually get joint injury and swelling from the psoriasis. These are some examples of the patches with the silvery scale on the left. On the right, you can see it can affect the nail, and it can come in some different morphologies. But typically, this is the general appearance I want you to be familiar with. Often treated with things like steroids, sometimes immunosuppressants like methotrexate, or biologic medicines like Humira and things that suppress the immune system. There's also coal tar, but a number of options, and often managed in conjunction with a dermatologist. Acne is a very common condition. It affects a lot of people, typically at the onset of puberty, often to the face, the chest, and the back. Um, Typically will have blackheads and whiteheads, which are called comedones. May have papules and pustules, can become nodulocystic, meaning having nodules and cysts. And the pathophysiology is basically a blocked hair follicle. You have a bunch of dead skin cells, and you have an oily substance that lubricates the hair follicle, and it's called sebum. And if you get blockage of that and you get infection with what's called P. acnes or Propionibacterium acnes, that creates infection and inflammation in that area. These are some of the presentations of the whiteheads, blackheads, a pustule where you have that pus-filled lesion on the top right, and then on the bottom left you have papules, that in that case a little red, so more of like an inflammatory papule. And then moving towards the right, cysts and nodules. These are deeper, fluid collections. The treatment is typically to discuss oil-free, fat-free, non-comedogenic cosmetics. So sometimes the cosmetics are comedogenic that people are using. And then for mild comedonal acne, usually a topical retinoid can do the trick. And then if there's comedonal and inflammatory, you might use the topical retinoid, such as tretinoin, with a benzoyl peroxide or azelaic acid, or a topical antibiotic, like other similar medicines to benzoyl peroxide, or clindamycin, etc. That is an actual antibiotic and kills the P. acnes bacteria. And then if that's getting worse, then they might have nodules. It might spread to areas that are tougher to treat, like the back and the chest. So we'll sometimes add an oral antibiotic, and then think about using a medicine called spironolactone, or in females using birth control pills, which can be helpful. And if it becomes really severe nodulocystic or scarring, then isotretinoin or Accutane is often the treatment of choice for these people and works very well, but has quite a bit more risk than the topical tretinoin and benzoyl peroxide. So, a quick note on skin cancer: you have squamous cell, basal cell carcinoma, and then you have melanomas. So, we call the first two non-melanoma skin cancers. Um, and Oftentimes, there's increased risk with fair skin, UV exposure, and there's a lot of important details to know about these. But for the athletic trainer, I kind of just want you to be familiar with the ABCDEs, and we'll talk a little bit about what that means. For squamous cell carcinoma, thinking about hyperkeratotic raised edges with a central ulceration. These can metastasize, but it's very rare, or more rare than melanoma, I'll say. And local excision is usually pretty curative. For basal cell carcinoma, the pearly rolled border, often with a central ulceration, can often be confused for squamous cell carcinoma. They can look similar. And it's very rare that these metastasize, but they can get very large and sort of have local damaging effects. Um, but the cure rate is basically 100% if you remove it early. For melanomas, this is a great opportunity to discuss the ABCDEs. So these are typically asymmetric, and have a sort of irregular border. Um, the color is often multiple different types of color, so more of a darkish and a brownish and a light brownish. For the diameter, it's usually greater than 5 millimeters, which is basically like a pencil eraser or larger. And then E for evolution or elevation, like is it raising, is it changing over time? And these do have significant malignant potential, so we want to be very vigilant about picking these up and getting people early treatment. And here again, kind of the asymmetry, the borders, the color, and the diameter, ABCD. And you can see on the top there is some more benign looking features, whereas on the bottom, more concerning features. And we want to encourage our patients to use good sunscreen practices, at least SPF 30, water resistant, applying 2 hours every 2 hours and after swimming or sweating, and then other forms of skin protection like hats and protective clothing. As we discussed, early detection sort of key, making sure that if a lesion is having any crusting or bleeding and it's not getting better over time, thinking about could this be cancerous and do we need to do any further evaluation? And then we'll talk very quickly about some can't miss rashes. These are not things that you need to be expert in at all, but just some general features that should raise red flags to get this person more urgent or emergent care. And we'll start with toxic shock syndrome, which is caused by an exotoxin from Staph aureus. The toxic and the shock, meaning fever and hypotension, usually with a diffuse erythematous non-pruritic, so it's usually not itchy, macular rash, and it can involve multiple systems. So they can have kidney issues, they can have GI issues, musculoskeletal issues. And this is often from some type of wound packing or a tampon, nasal packing that was left in place for a long time, and then they develop this infection. So the key is really source control, getting that material out, and then fluid resuscitation and antibiotics. And a sort of a general term that I'll use here is called exfoliative dermatitis. These are generalized skin inflammations that are diffuse, erythematous, warm, scaly, pruritic with peeling of the skin. And I want you to be thinking about drugs and cancers that can typically cause this type of presentation. And you could imagine if the skin is exfoliating and coming off, then there are major complications possible for volume loss, heat loss, any secondary bacterial infections, and changes in electrolytes. So people tend to get high doses of steroids or IV steroids, oftentimes admitted to the hospital, and they need pretty emergent dermatology consultation. And this is what that can look like. You can see the exfoliation on the left, and on the right there you see sort of like some fissuring and the skin sort of coming up. And there's a number of different forms of these drug eruptions that have often an overlapping classification schema. They're sort of thought to be different presentations or severities of a similar process. And often associated with penicillin, cephalosporins, or sulfa drugs as far as antibiotics go. And you want to be thinking about this anytime that somebody has an acute symmetric rash came on, quickly, and it's looking severe, red and scaling and exfoliative. And the spectrum goes from like an erythema multiforme to Stevens-Johnson syndrome to what's called toxic epidermal necrolysis. That's basically a increasing in severity and body surface area. So the toxic epidermal necrolysis is more severe, affecting a lot more body surface area, which you can imagine carries much more risk to the patient for a lot of the things we mentioned in the previous slide. So you want to make sure you stop whatever the offending agent is. We can use antihistamines for that itch, steroids for the inflammation in conjunction, and then thinking about what kind of higher level of care does this person need as far as critical care or hospitalization. So Stevens-Johnson syndrome, thinking about is there mucous membrane involvement. This is some uh, drug eruption pictures you can see on the top left, more of an erythema multiforme. It's like a little bit of targetoid rashes, a little widespread. On the right, you can see it's affecting a lot more body surface area, and you can see it's affecting the mucous membranes in this patient's mouth. And moving over to the bottom left, that's something called Nikolsky's sign, and that's where just gentle lateral pressure on the skin will actually cause the skin to basically detach. And then I want you to be familiar with the terms petechiae and purpura. These are often associated with conditions like vasculitides, different platelet disorders, which again, you do not need to be experts in, but being able to sort of pick this up and have a general idea of what's going on. So these are sort of pinpoint areas of bleeding or vasodilation. The way to take to sort of further investigate that is you say, okay, this area is red. If I press on it, does it blanch? Does it become white when I push on it and the red goes away? That means that it was just vasodilation in the area. Whereas if it is non-blanching, when I press on it, it doesn't change colors. That means that blood has extravasated. It's gotten out of the blood vessel. So we'd call that non-blanching. If it's very small, less than 3 millimeters, we call it petechia. If it's greater than 3 millimeters, we call it purpura. And the treatment depends on the etiology. Sometimes it could be steroids, different antibiotics. It might be plasmapheresis, actually sort of filtering the blood. But here's some pictures just to sort of be familiar. You can see some of these smaller areas of pinpoint little red spots, which would be petechia, and then sort of the larger lesions being purpura. And in that picture at the top there, you can see that when they press with a glass slide, that it becomes clear on the left, and the one on the right becomes, or it just kind of stays the same. So that means that the one on the right is non-blanching, the one on the left is blanching. And then a little algorithm on the bottom to just kind of think about when it is non-blanching. You can say, is the patient really sick looking and they have fever? If it's palpable, sometimes that's associated with disseminated meningococcemia, so meningococcal infection or gonococcal infection, which can be very severe. And then non-palpable, so you can't feel it, then might be associated with different clotting disorders. And then the patient who's febrile but not toxic, they don't look severely ill, then that sometimes is an autoimmune vasculitis or something called ITP if it is non-palpable. Again, don't need to be a expert here, but just a general idea of working through a thought process, making sure that you can communicate this to the treating physician. And then we'll talk about necrotizing fasciitis. This is the flesh-eating bacteria, and you usually will pick this up because of a substantial amount of pain, or what we call poop, or pain out of proportion. The rapid dissection along fascial planes of these gas-producing organisms causes crepitation, so you could get subcutaneous gas that when you press on it, you can feel sort of like crackling or crunching associated with the cellulitis. These are often polymicrobial, meaning a bunch of different bacteria, but sometimes things like Clostridia or different strep infections. These patients usually need broad-spectrum antibiotics right away, and getting surgery involved to say, for definitive surgical management. Here's an example on the left. You can see it kind of looks like a cellulitis, and it can progress quickly. And you can see in the picture on the right that you can get really devastating progression of the amount of tissue damage that this can cause, and people can get very sick. So you want to be having a high index of suspicion in somebody who has really severe pain and crepitus when you're palpating on these areas. If they're looking really sick, and then thinking about advancing to a higher level of care. Overall, some red flags to just be conscious of: fever, age, so people who are very young or very old, patients who look sick or have abnormal vital signs like hypotension, tachycardia. These things should be very concerning for you. Immunocompromised patients, people who have swollen lymph nodes, when you have really diffuse red skin, sort of that red all over, making you think about the exfoliative dermatitis that we talked about earlier. Different petechia, purpura, usually associated with some pretty scary conditions, or more significant that need to be managed quickly. Any new or recent medication changes within the last month. If it's associated with joint pains, any severe localized pain or tenderness, and if it's really rapidly or suddenly spreading. These are all things that I want you to be thinking about as red flags that really should make you stop and think, do I need to get a physician involved really early in this case?